Hi, everyone, and thank you so much for joining us today. My name is Emma Garrett, and I am one of the co-directors of the Addiction Nursing Fellowship, along with Maggie Tong, who's also joining us today. And it is my pleasure to introduce Deb Salverda, who has put so much work into creating this presentation, what we call the What's New in Addiction Nursing, where we have folks do a larger public lecture on a topic of interest and importance. And so I'll let Deb introduce that topic. But yeah, Deb is a team lead with the Interior Health in the South Okanagan with the Mental Health and Substance Use Services, and has been a wonderful fellow to have with us through this 2024-2025 year. And so I'll pass it over to you, Deb, to take us through the presentation and introducing that. I want to remind folks you can put questions or comments in the chat. It won't bug Deb during the presentation, and then I'll help moderate the Q&A session after. So you can, if things come up for you, you can feel free to put questions in the chat at any point during the talk. Okay, over to you, Deb.
Great, thanks, Emma. I just want to start today by thanking you all for being here and by acknowledging that I'm presenting today on the traditional, ancestral, and unceded territories of the Silks people, whose deep relationship with this land extends back since time immemorial. As a mother of two young women, a wife, daughter, sister, auntie, coworker, and friend, I reflect on the responsibility we all share to honor, protect, and learn from the land and those who've cared for it for generations. I express my deep gratitude to Indigenous communities for their ongoing stewardship, resilience, and teaching, which continue to shape our collective understanding of connection, healing, and community. This acknowledgement is more than just words. It's a commitment to listening, learning, and taking meaningful action towards reconciliation and justice. I don't have any conflicts of interest to declare. And to start, I want to provide a bit of context. According to the Canadian Substance Use Costs and Harms data from 2020, substance use was responsible for nearly 74,000 deaths in Canada that year, which translates to approximately 200 deaths per day. The overall economic burden of substance use in that year alone was $49.1 billion, equating to about $1,291 per person. Notably, more than 62% of these costs were attributed to two legal substances, alcohol and tobacco, highlighting the significant impact of both regulated and unregulated substances on public health and the economy. Opioid use alone accounted for $7.1 billion, the highest recorded in any year studied. And sadly, nearly 75% of these costs stemmed from lost productivity, largely due to premature deaths among people using opioids. These statistics emphasize the urgent need for comprehensive and innovative public health strategies, harm reduction initiatives, and policy interventions to mitigate the devastating personal, social, and economic consequences of substance use in Canada. So on that note, I feel truly honored to speak on this important topic, the role of peers in transforming addiction care through lived experience. This is a subject that is not only professionally significant to me, but also deeply meaningful in the broader landscape of addictions care. Helping to develop the peer program for the South Okanagan has been one of the most humbling and rewarding experiences of my career to date. Through this work, I've witnessed firsthand the transformative impact that peers, or people with lived and living experience, can and are having on the healthcare system. As part of my fellowship, I've had the privilege of engaging in focus groups for a quality improvement project with Interior Health and our peer advisory group, specifically looking at the role of peer work in early recovery. This experience has deepened my understanding of both the strengths peers bring to the field and the systemic challenges they face. I want to acknowledge that I'm not here to speak for peers or people with lived experience, but rather to provide an overview of peer programs for those working alongside peers or those interested in developing peer programs. So today I want to explore how peers are not just valuable contributors to care teams, but really essential leaders in the movement towards a more compassionate, person-centered, and effective addiction care system. We'll discuss the unique strengths that peers bring to clinical and community settings, some of the challenges they encounter, and what healthcare providers, policymakers, and advocates can do to support and elevate this work. So it's not just about integrating peers into existing models of care, it's about shifting the way we think about expertise, leadership, and healing in the field of addiction medicine. In terms of the objectives, we'll review peer roles, look at the evidence and why it matters, and consider some of the challenges and opportunities and contemplate future directions. By the end of the session, I hope to leave you with a deeper understanding of why lived experience is not just valuable, but vital in transforming addictions care. So while many healthcare professionals have personal experience with substance use, peers are explicitly asked to share their stories to build trust, foster understanding, and empower others. Peers combine lived experience with formal training to promote resilience, mind-body recovery, and evidence-based care. Peer support intentionally centers lived and living experience as the foundation for connections and systems change. This approach bridges traditional healthcare and the communities it serves, fostering more equitable, person-centered care. There are several different terms that are used in the literature. For example, person with lived and lived experience, or people who use drugs, or person who uses drugs. But for the purposes of this presentation, I'm going to use the term peer. That said, I do want to recognize that language matters deeply in substance use care, as the terms we use influence the attitudes and experiences of both those providing and receiving support. Terminology is constantly evolving, and what feels respectful today may shift over time. As we navigate these discussions, it can sometimes be difficult to know which words will be most inclusive and affirming. So I want to acknowledge that I might not always get it right, and for that I apologize in advance. My goal is really to create safe and brave spaces where open dialogue can happen, and we can collectively engage in the learning process. Being mindful and respectful in our language fosters an environment that supports everyone's growth and well-being. So peer support or peer work is defined by using lived experience to support others in recovery. This flexible role can be fulfilled on a volunteer basis, usually with an honorarium, or as a paid position. Peer workers build trust, foster engagement, and reduce stigma by sharing their personal recovery journeys, guided by the principles of mutuality, empathy, and shared understanding. This multifaceted contributions include harm reduction, providing education, distributing harm reduction supplies, promoting safer substance use practices, and treatment navigation, helping individuals access detox, recovery programs, housing, and other essential services. Peers are involved in crisis support through emotional care and de-escalation, and policy advocacy to ensure lived experience really informs service design. Integrating peers into the healthcare system really fosters a more accessible and culturally safe approach that really meets people where they're at. People have been helping each other since time immemorial, so peer work is not new, but offering support, guidance, and community through shared experiences. However, peer work as we understand it today has some deep historical roots, beginning with mutual aid groups that were founded on the belief that people with lived experience offer unique and essential support to others facing similar challenges. One of the earliest and most influential examples is Alcoholics Anonymous, which was founded in 1935. It introduced a 12-step model, emphasizing shared experience, peer-led support, and a spiritual framework for recovery. It successfully demonstrated the power of peer connection in sustaining long-term recovery and paved the way for later groups. Narcotics Anonymous emerged in the 1950s, which adapted the 12-step approach for individuals recovering from a broader range of substance use challenges. And then in the 1990s, we saw Smart Recovery, which was developed as an alternative focusing on self-empowerment, cognitive behavioral strategies, and scientific principles rather than more of a spiritual framework. And this expansion helped diversify the ways in which peers could be integrated into substance use beyond abstinence-only based programs. During the 1960s and 70s, the counterculture movement really marked a radical shift in societal norms. It was driven by youth challenging traditional politics, lifestyles, and cultural values. A key element of this area was increased use of psychedelic drugs, which not only questioned the mainstream view of drugs as solely harmful or criminal, but also highlighted their potential for positive transformation. This embrace of more alternative perspectives directly confronted prevailing beliefs, laying the groundwork for more compassionate, peer-led approaches to addiction recovery. The movement's emphasis on communal living, mutual aid, and alternative lifestyles helped catalyze the development of harm reduction strategies that have become key to treating substance use disorders today. Although direct peer involvement in harm reduction, in harm reduction during this time isn't extensively documented in the literature, the initiatives established a foundation for community-based approaches that prioritize lived experience. From the 1970s to the 1990s, peer work evolved alongside the harm reduction movement, which shifted from punitive abstinence-only approaches to health-focused strategies, which emphasized safer drug use, education, and community support. A major turning point came in the 1980s with the HIV/AIDS epidemic, as the rapid spread of HIV among people who injected drugs highlighted the urgent need for public health interventions. activists, health professionals, and people who use drugs pushed for harm reduction policies, including needle exchange programs and peer-led education to reduce disease transmission. Peers played a key role in these efforts, using their trusted relationships to distribute harm reduction supplies, provide overdose prevention education, and challenge stigma. This period really formalized peer work within harm reduction, recognizing lived experience as essential to effective public health responses. In the Netherlands, the Medical Social Service for Drug Users was among the first programs to integrate peers into outreach, education, and service delivery, inspiring similar models worldwide. By the 1990s, harm reduction had become an international movement, with peer-led programs, supervised consumption sites, and drug user advocacy organizations really gaining momentum in North America, Europe, and beyond. These efforts laid the groundwork for peer work today, demonstrating that centering lived experience leads to better health outcomes and stronger policy change. During the 1990s and 2000s, the overdose crisis intensified, particularly in the downtown East Side. Rising rates of fatal overdoses, HIV, and hepatitis C among people who use drugs demanded urgent community-driven responses. In 1998, the Vancouver Area Network of Drug Users, or VANDU, was formed. VANDU was created by and for people who use drugs, making it one of the first organizations to really center peer work in harm reduction and policy advocacy. Peers took the lead in street outreach, safer drug use education, and challenged laws and policies that criminalize people who use drugs. Their activism played a key role in shaping health interventions. By the early 2000s, the need for innovative public health interventions really became undeniable. In 2003, Insight, which was North America's first supervised injection site, opened in Vancouver. Insight was groundbreaking not only for its harm reduction model, but also for its integration of peer workers. Peers were involved in all aspects, from supporting clients to advocating for policy change. And these efforts really helped shift harm reduction from the margins into public health policy, proving that when people with lived experience lead harm reduction efforts, lives are saved and communities become stronger. Health organizations really began formalizing peer work in the 2000s, recognizing its critical role in reducing stigma, improving treatment engagement, and supporting long-term recovery. What began as grassroots harm reduction and advocacy efforts has gained legitimacy within the healthcare system. As peer movements have grown, academic research has increasingly validated its effectiveness as well, and studies show that peer support improves treatment retention, reduces relapse rates, and helps address barriers to care. Organizations like the Substance Abuse and Mental Health Services Administration in the US and the Canadian Centre on Substance Use and Addictions in Canada have played a significant role in shaping peer support, training, and policies, and these efforts have really helped to legitimize peer work and contribute to its growth. So peer work today spans the whole substance use services continuum, strengthening healthcare systems worldwide. By centering lived experience, peers build trust, enhance engagement, and influence policy. But harm reduction remains a core approach, reducing risk while promoting well-being. Advocacy also continues to challenge stigma and expand access to care. I think peer work is really expanding, which is exciting. For example, St. Paul's Hospital now has 20 peers working within its addiction medicine team in the Road to Recovery program, compared to just 5 years ago. And in the South Okanagan, we have over 30 peers now within our mental health and substance use program, which are accessible across all program areas, whereas 5 years ago, we had none. I think it's also important to note that many of these positions are volunteer-based, and we're really pushing for more paid positions as well. So as peer work becomes more embedded in healthcare and community programs, it really does remain a driving force for meaningful change in substance use. So a quick look at some global perspectives. So Portugal has been a global leader in peer-led harm reduction, integrating people with lived experience into drug policy and frontline services. CASO, and I'm not going to try and pronounce it, is a peer-led association which advocates for harm reduction, policy reform, and the rights of people who use drugs. CASO ensures peer voices shape policies and services while maintaining independence, allowing peers to advocate freely regardless of their drug use status. There's several organizations which provide peer worker training that leads to paid employment, challenging the idea that drug use should be a barrier to work, education, or inclusion. By funding peer roles, Portugal recognizes peers as essential, not supplementary workers, reducing stigma and empowering people with lived experience to lead harm reduction efforts and influence policy. Peers are employed across the continuum from drug consumption rooms to outreach programs that connect people to housing, healthcare, and social services. Portugal's 2001 decriminalization laws expanded opportunities for peer leadership in harm reduction. However, there were some changes in 2008, which reintroduced criminalization for possession over a 10-day supply, which created some renewed tension between public health and punitive policies. So peer organizations like CASO continue to push for a fully health-based approach that prioritizes harm reduction over punishment. Australia has integrated peer-led initiatives into its harm reduction framework as well, with government support, ensuring that these programs will eventually operate at scale, or that's the hope. Peer-run organizations like Peer-Based Harm Reduction Western Australia provide overdose prevention, peer education, and harm reduction outreach. This group is part of a national network of Australian drug user organizations and a member of the Australian Injecting and Illicit Drug Users League, which is a national peak body for peer-based drug user organizations. These groups use some innovative strategies like postal-based supply delivery and mobile services to reach people. Research in Australia has really highlighted the effectiveness of peer-led harm reduction, showing improved accessibility and health outcomes. Australia's funding model really supports peer-run services essential, but there's a key challenge remaining, which is expanding access to rural and remote areas. So as another geographically large country, Canada faces similar barriers, requiring sustained investment and policy commitment to ensure harm reduction services can reach all communities. Scotland has also faced significant challenges with high drug-related mortality rates. In response, the nation has developed some progressive peer-driven programs to address substance use and support recovery. The Scottish Recovery Consortium plays a pivotal role by integrating individuals with lived experience into recovery communities. There's other organizations like We Are With You Scotland, which train and employ peers to provide support within community settings. The Scottish government's rights, respect, and recovery strategy underscores this approach and highlights the importance of peer-led recovery hubs and commitment to supporting the growth and expansion of Scotland's recovery communities into wider community settings. Norway has also emerged as a leader in peer-based addiction treatment within the Nordic region by integrating individuals with lived experience into harm reduction and recovery initiatives. In Norwegian cities, there's some innovative housing first programs which support individuals facing both substance use and mental health challenges by prioritizing immediate unconditional access to stable housing, something I know we could really use here. Often with the assistance of peer support to ease transitions from hospitals to long-term living situations. Additionally, there's organizations like the Association for Humane Drug Policy, which is actively involving those with lived experience in shaping harm reduction policies, advocating for user participation, decriminalization, and a human rights-based approach to drug regulation. A standout best practice in Norway is the deployment of peer navigators in both hospital and housing settings, who are there to build trust with clients, guide them through our complex healthcare systems, and support their journey towards recovery and stability. New Zealand has also taken a strong peer-led approach in addiction recovery by prioritizing Maori-led models and robust peer governance. Unlike systems where peers supplement clinical teams, New Zealand's programs really empower individuals with lived experience to design and lead services that emphasize cultural responsiveness, self-determination, and community-based recovery. They have one great example of a methamphetamine harm reduction initiative called Te Ara Oranga, which integrates peer workers into law enforcement, health, and social services to support intervention and treatment, with peers playing a central role in outreach, harm reduction education, and linking individuals to support networks. Consumer-led addiction recovery programs are also empowering people by giving them decision-making power in service design and delivery. So this approach, which emphasizes that peers should lead their own services and highlights the importance of Indigenous leadership, offers some valuable lessons for Canada as we're working to integrate more peer-driven models alongside a more clinician-led system. And in the research, I really did find that Canada is recognized as a global leader in harm reduction and has been increasingly integrating peer involvement in addiction care. We have some great national advocacy organizations like the Canadian Centre on Substance Use and Addiction and the Canadian Drug Policy Coalition, which are actively pushing for the inclusion of peers in policy development and service delivery and research. So although we have come a long way, there's still a lot of work and room for growth, particularly in scaling up peer-led programs beyond major urban centers and embedding peers more meaningfully within healthcare systems. So why peers? I think research consistently demonstrates the positive impact of peer involvement in substance use care. Peers, we know, build trust and rapport, they humanize care and make services more accessible. Their presence fosters hope, showing that recovery is possible. And peer-led initiatives really reduce stigma, encouraging greater engagement with treatment and improving health outcomes. Studies over the last 3 decades and across the substance use services continuum confirm that peer support enhances recovery, reduces stigma, and improves overall well-being. Back in 2004, Solomon found that peer support fosters empowerment and reduces socialization, both key factors in long-term recovery. Boisvert and others in 2008 showed that peer mentoring aids long-term sobriety and supports community reintegration. In 2011, Rapper and Carter demonstrated that peer involvement makes treatment more accessible and improves recovery outcomes. In 2016, a systematic review by Basuk and others found that peer services reduce substance use and strengthen recovery capital. And in 2022, Viking and others highlighted how peer support shifts team practices as well, enhancing engagement and lowering healthcare costs overall by reducing reliance on more intensive interventions. So really the evidence is pretty clear that peer programs play an important role in harm reduction and long-term recovery strategies, and they improve things for both the individual and at a system level. In 2014, Reef and others conducted a really comprehensive review of peer recovery support services for individuals with substance use disorders. And they looked at peer-led models such as coaching, mentoring, and support groups. And their findings indicated that peer support is associated with reduced relapse rates, increased treatment retention, and stronger social support networks. They also found that peer involvement enhances relationships with treatment providers and fosters higher satisfaction with treatment experiences. The review did highlight some methodological limitations in existing research, noting that many of the studies to date had small sample sizes and lacked rigorous designs, making it difficult to isolate some of the more specific effects of peer support. So they emphasized the need for further research to strengthen the evidence base and better understand the unique contributions of peers. There's some really good examples of successful peer programs, including one here in rural British Columbia that has seen success with innovative peer-led models for oat and safer supply programs. And these initiatives really help overcome barriers in rural areas like limited access to healthcare, stigma, and engagement challenges by increasing accessibility, fostering trust, and creating more non-judgmental spaces for support. Research from the This Is PEEP study by Greer and others showed that when peers design and implement services, programs become more user-friendly, culturally relevant, and responsive to community needs. Similarly, Scow and others' study on peer-led safer supply and oat distribution in rural BC, research which was notably peer-led and authored, found that peer-run models enhance trust and engagement, leading to improved treatment retention and reduced overdose risks. I think these type of successful initiatives really demonstrate that integrating lived experience into service delivery can transform harm reduction and improve health outcomes, particularly in underserved communities where we need to really increase peer support programs. So we've seen how peer work benefits clients, but increasingly we're also seeing in the research that it's transformative for the peers providing support as well. So engaging in peer work provides meaning and purpose in recovery. It reinforces one's own journey while helping others. It also creates opportunities for skill building and career development, often leading to roles in harm reduction, healthcare, and recovery services. And beyond professional growth, peer work fosters connection, which reduces isolation and strengthens a sense of belonging, which we all know are really important. This dual benefit, enhancing both the lives of clients and peers, demonstrates why peer work is such a powerful and sustainable model. And research also confirms that peer work is not only impactful for those receiving support. I think this research by Scammell describes this as by helping others, we help ourselves, capturing how peer work fosters a renewed sense of direction and strengthens one's own recovery. Studies also emphasize the role of connectedness, as peer work reduces isolation and builds recovery-oriented relationships, ensuring peers remain part of a supportive community. The research also highlights that peer roles create pathways for employment and increase self-efficacy. And this growing body of evidence confirms that peer work is a mutually beneficial model that strengthens both the individuals and the broader system of care. This review by Bailey and Tickle looked at 11 qualitative studies on the impact of employment as a peer support worker, highlighting both benefits and challenges. Key benefits included the enhanced personal recovery through a greater sense of purpose and meaning, improved self-esteem, and increased confidence and personal growth. They also found that peer roles offer professional development opportunities through training, skill building, and career advancement. But the study also highlighted some challenges such as role ambiguity, where a lack of clarity and responsibilities can create stress and uncertainty for peer workers, and boundary issues as navigating the line between personal recovery and professional involvement requires some ongoing guidance and support. The emotional toll of helping others in recovery was another noted challenge, emphasizing the need for really strong support systems. The study found that consistent evidence of the value of peer support work for both organizations and peer workers, but also highlighted some gaps in the research, calling for more high-quality qualitative studies to better understand how peer work impacts personal recovery. I think overall, the research overwhelmingly shows the benefits of peer involvement outweigh the risks, and many of the risks are more related to the impact on peers themselves due to a lack of appropriate support systems or burnout in the context of an under-resourced healthcare system. I love this one quote from our focus group where someone said, "I remember thinking I'd never get out of the place I was in. Now I meet people who feel the same way, and I can show them that change is possible." Stigma, unfortunately, remains a significant barrier for peers working in the substance use field. It affects their roles, credibility, and overall work experience. Research also highlights these challenges, emphasizing the need for cultural shifts within healthcare, including education, training, and structural support to ensure meaningful peer integration. Many studies indicate that peers face both direct and indirect stigma within healthcare settings. Direct stigma arises when healthcare professionals question the legitimacy or professionalism of the peer role, which can lead to feelings of marginalization and discouragement. Indirect stigma occurs when peers witness discrimination towards service users, contributing to emotional exhaustion and burnout. And unfortunately, we have still seen this quite a bit. This environment can erode the well-being of peer support workers and hinder their ability to effectively support those in need. So addressing these stigma-related challenges through comprehensive training, policy reforms, and supportive workplace cultures is really crucial. Implicit and explicit biases among healthcare professionals also contribute to stigma towards peers, making integration into teams more difficult. So implicit bias refers to the unconscious stereotypes that we all have that influence interactions, while explicit bias involves conscious beliefs that may marginalize peers. These biases can undermine credibility, limit opportunities, and create isolation, which will ultimately impact team collaboration and has a negative impact on patient care. Addressing bias requires a lot of self-reflection, bias reduction training, and active support for peers and healthcare teams. And organizations also really have to commit to anti-stigma policies and peer integration efforts to foster inclusive workplaces. So reducing bias strengthens collaboration and improves care for everybody. One of the most prevalent forms of discrimination that peers face is workplace microaggressions. So these are the subtle but harmful interactions that question their competence and undermine their professional contributions. So some research by Moran and others in 2019 highlighted that peers often encounter dismissive attitudes from colleagues who view them as less credible due to their lived experience rather than formal training. This can lead to doubts about their competency, leading to exclusion from key discussions or decision-making processes. It also contributes to isolation in a workplace setting, and this can contribute to increased job turnover or burnout. So this discrimination stems from a persistent belief that lived experience is not as valuable as formal education, despite evidence supporting the effectiveness of peer-led interventions in improving health outcomes. So the impact of workplace discrimination on peers is significant and does reinforce stigma rather than breaking it. In looking at equity in hiring practices, something of note is that there is very little definitive information in the literature to support requiring periods of recovery or abstinence prior to being hired into peer roles. Health authorities do not require other healthcare employees to disclose personal recovery timelines, making it problematic and inequitable to impose such a requirement solely on peers. The expectation that individuals with lived experience must meet an arbitrary period of abstinence or recovery before being considered fit for employment actually reinforces stigma and creates unnecessary barriers to meaningful work. The standard not only contradicts the principles of harm reduction, but it also assumes that recovery is a linear process that can be universally measured by time rather than an individual's readiness, growth, and stability. Since peer workers bring their lived experience as a professional skill, their ability to do this work should be assessed more on their capacity to share their story safely and effectively rather than a prescribed time frame. True recovery is really a deeply personal experience and cannot be dictated or defined by an external authority. So readiness for peer work should be determined through self-assessment, interviews, mentorship, and a supportive work environment that prioritizes both the well-being of the peers and the people that they're supporting. One study in Ontario found that 59% of paid peers identified career stagnation as a major issue, citing unclear role expectations, limited involvement in decision-making, and workplace isolation as key barriers to professional growth. Peer roles are unfortunately often seen as entry level rather than a sustainable career path with few opportunities for advancement into leadership or clinical positions. Some financial and systemic barriers can also prevent peers from accessing education or certifications needed for career development. So to support long-term career sustainability, organizations need to develop clear career pathways with structured opportunities for professional advancement. Research by Basuk and others emphasize that many peer workers enter roles with limited training, which can lead to challenges in service delivery and personal well-being. The Peer Engagement Principles and Best Practices Guide, developed by Greer and others, offers comprehensive strategies for effectively involving peers in health service planning and delivery. This guide emphasizes that peers are experts in their own experiences, providing valuable insights that enhance the effectiveness of health programs. Some key recommendations include fostering equitable participation by involving peers early in decision-making processes, ensuring fair compensation, and addressing barriers such as stigma, and the importance of organizational support, including leadership commitment, to create environments which are conducive to meaningful peer engagement. By implementing these best practices, health authorities and service providers can develop more responsive and effective harm reduction initiatives that truly reflect the needs of the communities that they serve. Another 2019 study by Eddy and others highlighted the challenge some peers may face in maintaining professional boundaries, emphasizing that unclear role definitions can lead to over-involvement and some potential ethical dilemmas. Another study by Kane and others in 2023 also identified role ambiguity as a major challenge for peers. Peers play a unique and essential role in substance use care, leveraging their lived experience to build trust and reduce stigma. However, this dual identity as both a professional and an individual with lived experience can present some unique complexities. In the absence of clearly defined roles and consistent training, peers sometimes find themselves navigating responsibilities that fall outside of their intended scope. So dual relationships, such as supporting former using partners or friends, can also blur the line between professional support and personal connection. And limited organizational support and unclear guidelines around things like confidentiality and digital communication can exacerbate these issues. So research really underscores the need for clear role definitions, structured support, and targeted training. And addressing these challenges is crucial for empowering peers to ensure sustainable ethical support. Peers in substance use settings obviously offer vital emotional and social support to individuals facing some significant challenges. So while their lived experience fosters strong connections with clients, it can also increase the risk of compassion fatigue or a state of emotional exhaustion that can lead to burnout. Some research by Tracy and Wallace highlighted how the intensity of peer support roles can strain mental and emotional well-being, sometimes manifesting as fatigue, reduced empathy, or heightened stress and instability in personal recovery. And I think this is something that we're struggling with a lot in the mental health and substance use field in general. So to mitigate these risks, organizations need to offer access to mental health benefits, establish peer-led support systems, and provide training on self-care, emotional resilience, and trauma-informed peer work. Implementing these sorts of measures is really essential for sustaining effective peer programs while protecting the well-being of both peers and basically everyone working in this field. Compensation for peers is another key consideration. Despite their essential role in substance use services, peer compensation unfortunately often still falls short of economic realities. Fair remuneration is critical for financial stability and recognizing lived experience. The BC Centre for Disease Control has a peer payment standards guide, and there's other resources which provide some best practices. And there's reports like the Canadian Centre for Policy Alternatives Out of Control Rents, which really highlights the gap between wages and the cost of living and really emphasizes the need for livable wages. So of note in BC, honorariums for peer work are exempt from income and disability assistance, which reduces some financial barriers. Compensation also really varies by role. Some standard rates are usually $25 to $30 an hour for meeting participations, on-call peer support around $100 a day, focus groups between $25 and $50 an hour. And then things like public speaking events can range from $50 to $200 per event. But I think it's really important to note that few peer roles are full or even part-time, and honorarium-based peer positions often have really limited hours. So that can make it really difficult for people to stay engaged. Ensuring wages align with real living costs is also essential for workforce retention and dignity, and sustainable compensation models really have to reflect inflation, regional expenses, and peer input to ensure financial security and equity. Compensation for peers really varies widely depending on organizational policies, available funding, regional guidelines, when there really isn't any standardized rates in place. It's essential to establish clear and transparent agreements before engagement, ensuring that peers fully understand their compensation and any associated expectations. And organizations really should also consider additional expenses that peers may incur, like transportation, childcare, preparation time, to ensure fair remuneration. Some best practices in BC emphasize providing equitable pay that reflects skills, experience, and responsibilities of the peer roles, and really should try and align compensation structures with established guidelines to recognize the valuable contributions of peers and maintain sustainable peer programs. Successful peer integration into teams requires really intentional policies and structured onboarding to foster inclusion, clarity, and collaboration. Inclusive hiring practices recognize lived and living experience as an asset from the outset. As previously discussed, clear role definitions set expectations, reducing ambiguity and fostering mutual respect. And ongoing team building efforts are really needed to help build relationships and address misconceptions about peer roles. And training for all staff, including managers and supervisors, is also really important. Creating an inclusive workplace means embedding respect for peer contributions into organizational culture. Addressing stigma through education and advocacy is essential, as misconceptions can create barriers for peer workers. Providing staff-wide training on the value of lived experience fosters greater acceptance and collaboration. And organizations really should seek peer feedback regularly to improve policies and workplace conditions. Actively involving peers in decision-making ensures their perspectives shape a safer and more inclusive work environment. So to support peers meaningfully, we need intentional training, reflective supervision, peer mentorship to foster growth and skill building. Debriefing and feedback loops offer space to process challenges and provide input, and support networks and self-care initiatives to promote wellness and connection. Education and training for healthcare teams, including leadership, helps integrate peers as valued members, not tokenistic roles. Addressing bias and stigma through inclusive language and policy is essential, and supportive workplaces need to include collaboration, shared decision-making, and recognition of peer contributions, and of course, fair pay benefits and career development pathways are really important for long-term sustainability of peer programs. Peers experience multiple overlapping social identities that impact their work and well-being, like factors like race, gender, disability, and socioeconomic status can also compound challenges such as stigma, discrimination, and access to resources. So to foster inclusion, organizations should implement equitable policies, provide tailored support, and ensure more meaningful representation and decision-making. Creating spaces that acknowledge and address these complexities strengthens peer well-being and the effectiveness of peer support. Before I continue, I want to talk a little bit more about peers across cultures, but I also want to recognize that conversations about Indigenous knowledge, healing, and peer work are not mine to lead, but rather spaces where I continue to learn. I think sometimes the fear of saying the wrong thing can lead to saying nothing at all. However, I was recently reminded in a presentation by Len Pierre that reconciliation and meaningful change require action, even when it feels uncomfortable. Allyship is not a destination, but rather a lifelong process of learning and unlearning. So with that in mind, I want to acknowledge the rich knowledge embedded in Indigenous ways of knowing and healing, and how these teachings offer valuable insights for healthcare and peer support. Peer work really aligns closely with many Indigenous traditions, and ensuring strong representation of Indigenous peer workers in healthcare and addiction services helps reduce barriers and provide culturally safe care. Systemic racism and ongoing colonialism continue to shape healthcare and social systems, and recognizing Indigenous knowledge as vital to healing is part of a broader process of decolonialization. Centering Indigenous-led peer programs and culturally safe practices strengthens support networks and ensures that care aligns with cultural values and identities. Holding these teachings within healthcare, or honoring these teachings within healthcare, isn't just about inclusion, it's about improving care for everyone. Indigenous knowledge systems emphasize relationality and reciprocity, values that closely align with peer work. Relationality recognizes the interconnectedness of individuals, communities, the land, and traditions, while reciprocity fosters mutual exchange and shared responsibility. In many Indigenous traditions, those who have healed from trauma or substance use give back by mentoring others through storytelling, ceremonies, and healing circles, mirroring peer work's emphasis on relationship building and mutual support. Indigenous-led peer models prioritize collective well-being over hierarchical structures, reinforcing the idea that healing is a shared journey. Integrating these principles into peer support frameworks strengthens connections, promotes holistic community wellness, and honors Indigenous ways of knowing. Indigenous healing frameworks emphasize spiritual, emotional, physical, and mental well-being, contrasting with Western medicine's often narrower focus on individual pathology. Ceremony, storytelling, and other cultural traditions lie at the heart of Indigenous health, fostering identity, resilience, and connection. Storytelling as an oral tradition transmits knowledge, strengthens community bonds, and offers a culturally grounded method for processing trauma. These principles align closely with peer support, where lived experience is shared to foster healing and empowerment. Narrative-based approaches create shared meaning, validation, and connection in substance use recovery. By integrating Indigenous healing practices into peer support models, services can become more culturally safe, trauma-informed, and community-driven, which ultimately improves outcomes in substance use care for everyone. Indigenous healing is also deeply connected to relationships with the land, water, and natural cycles, emphasizing wellness as an interconnected process rather than an individual experience. Western addiction treatment often prioritizes clinical settings, while Indigenous models focus on land-based healing, ceremony, and community-driven care. Decolonizing care requires shifting from institutionalized, professional-dominated frameworks to community-led, culturally grounded approaches that center Indigenous leadership and traditions. Peer support aligns with these principles by challenging colonial hierarchies, valuing lived experience and relational knowledge over professional authority, and recognizing the expertise of those with lived experience. Moving beyond institutional settings, peer support can integrate nature, ceremony, and cultural practices to create healing spaces that reflect Indigenous ways of knowing. By embracing Indigenous knowledge and peer-led healing, addiction care becomes more inclusive, sustainable, and culturally safe, ultimately honoring community wisdom and fostering deeper connections in the recovery process. Indigenous peer support also acknowledges that colonial trauma, including the impacts of residential schools, the 60s scoop, and systemic racism, profoundly influenced substance use. While Western peer support models often focus on individual experiences, Indigenous approaches emphasize the significance of historical and collective trauma. To be effective, peer support must be trauma-informed and culturally safe, addressing the root causes of substance use. This involves recognizing how historical trauma contributes to substance use as a coping mechanism for unresolved grief and anger. By integrating Indigenous ways of knowing and healing, peer support can foster resilience and recovery, moving beyond individual pathology to encompass community and cultural restoration. So some key takeaways should be relational, not transactional. It's about reciprocity, not charity, holistic, not medicalized, decolonial, not hierarchical. It's about storytelling, not just a diagnosis. And it's should be land-based, not just office-based. Indigenous peer work is not just about recovery from substance use, it's about reclaiming identity, culture, and community strength. So by integrating these principles, peer support models can become more inclusive and effective for all. So future research is crucial to strengthening peer workforce development and ensuring sustainability. One key area is to look more into equity and intersectionality, recognizing how factors like race and gender can shape peer experiences. Understanding culturally responsive approaches is also vital, ensuring peer support reflects diverse healing traditions. And long-term workforce and client outcomes remain underexplored. Research also needs to examine the sustained impact on peer roles on recovery, relapse prevention, and peer work in early recovery needs further study, as entering the workforce early can present unique challenges and opportunities. From the peer perspective, research should assess risks and benefits, including stigma within healthcare systems and systemic barriers that peers may be encountering. And geographic disparities also warrant more attention because the realities are quite different between urban settings and more rural places. And research on sustaining peer well-being and career growth is also critical. Understanding how to scale up successful peer models is also really important. While peer work has expanded, it's still really inconsistently integrated across healthcare systems, and peers really need to be included at all levels of care, not just in harm reduction, but in all areas of treatment and recovery. Accessible and standardized training is also essential, not to impose rigid structures, but to ensure peers have equitable access to knowledge, skill building, and career opportunities. And research is another key area for growth, particularly peer-led studies that center lived experience in shaping best practices. And there's some interesting stuff coming up too around digital platforms that can maybe help expand peer support to underserved communities, ensuring that those in rural and remote areas also have access. Peers really bring valuable insight, not just to the frontline work, but to policy and system design. And their inclusion really has to go beyond surface level representation. And peers need a real voice in decision-making at all levels. So true inclusion means ensuring their expertise is actively shaping the future of substance use treatment. Peer work aligns with justice doing by prioritizing ethical relationships, power sharing, and system accountability. It fosters dignity, trust, and mutual respect, moving beyond transactional care to create relationships that are rooted in solidarity and shared responsibility. By challenging traditional hierarchies, peer work ensures that care is trauma-informed and person-centered rather than dictated by a system that has historically excluded and even harmed people who use substances. Engaging and including peers at all levels strengthens services and creates more equitable care. But to truly integrate peer work, we have to remove systemic barriers, ensuring that peers are not just present, but are shaping services and leading change. Sustainable peer work requires long-term investment in funding, research, and supports to prevent programs from being underfunded or tokenized. Justice doing also demands ongoing advocacy, shared accountability, and the courage to challenge inequities. So peer work is not just about individual healing, but about transforming systems to be more just and inclusive. So by committing to this work, we can shift addiction care toward a more effective model. And for anyone who's interested, Vicki Reynolds' work offers some really good insight into understanding justice doing in practice. So lived experience is not just an add-on, it's an asset that strengthens substance use care. By integrating lived experience in decision-making, we can create more effective, responsive services. A truly transformed system is one where policies, services, and innovations are shaped by those with direct experience, ensuring care is effective and reflective of real needs. So as one focus group participant perfectly summed it up, we are part of the change that's got to come. So peers are not only voices to be heard, they're leaders to be followed. And I just have some references there. And image credits. And thanks everyone for joining today and letting me talk on this important topic.
Thank you so much, Deb. What an amazing and super comprehensive presentation. I enjoyed it so much, and yeah, really grateful for all the work you put into that. I want to give folks the chance to put some questions into the chat for Deb. And maybe as folks are, sharing their thoughts and their thanks and potentially some questions, maybe I'll just get us going by, I guess thinking about what's next, like what you would recommend for people who are hoping to bring peers into their programs. Just how to grow this, especially sort of thinking about our context in BC.
I think just looking at sort of how things evolved in the South Okanagan, and there's obviously still work to be done, but just being creative and innovative. And like I said, it's been a humbling experience. We got lots wrong and we got some stuff right too. But being willing to sort of take the challenge. I think a key thing is really advocating for sustainable funding models. And I think it's good to have a variety, like we've, we need more paid peer positions for sure, but having volunteer options are also really great because not everyone is looking for interested in a full-time or part-time position as well. So having a big complement of services available is also important so that can meet different people's needs. I think just advocating, I think just we all have roles as healthcare professionals to really advocate for peer support at all levels, and doing the peer focus groups, having peers say how important it would have or how much of a difference it might have made to them to have someone do the kind of work that they're doing when they were going through their own struggles, especially in the acute settings. I think, some places there's some really, when I was doing my travels around for clinical placements, there's a lot of variability in how peer programs are being rolled out across the province. Some have really robust peer programs in acute settings, some more in community, but I think just recognizing the importance of peer support at all levels of care in acute and in community.
Yeah, Tamara has put a comment in the chat that peers absolutely need to be implemented into our hospitals for those individuals and bridging the gap for healthcare workers and clients. I have to say in my experience, like some of the most I've learned has been from working with peers as a nurse. It's so humbling and really transformative, both of my view of the work, what we're able to offer as healthcare professionals, but also seeing this bridge, like seeing clients sort of trust their healthcare teams differently when they see that peers are part of the healthcare team. They're like, okay, that, I trust this person, and this person seems like they're pals with those other people. And so it's like a really amazing bridge.
I think it just keeps the system accountable in a different and really important way. And we know health outcomes haven't been what we would have liked them to be. And when you look at sort of the toxic drug crisis and how things have continued to play out in the province, I think we just need to look at new and innovative ways of doing things too, and listen to the people who need it and are using the services about what worked and what didn't work, and being okay with that feedback. Not taking it personally, but being open to how we have to do things differently.
Really like that. Yeah, that comment about accountability, it makes sense, and not making assumptions, right? And like just always consider where your like frame of reference is coming from. There's a comment from Amrit, thank you for joining. Amrit's the peer coordinator at St. Paul's, and thoroughly enjoyed it and being part of such an amazing peer team at St. Paul's. And then Kira shared, I'm currently the first paid peer support on my team, so I'm finding the path to finding ways to legitimize or sell how important this care is challenging. I haven't seen the BCCDC guide on peer engagement principles before, so thank you for sharing that. And certainly we'll be reading that more to create a more well-rounded understanding of the peer role. Yeah, have you come across any other good resources, maybe even for healthcare professionals to learn about peer work, like folks who haven't had a chance to work with peers and, you know, not sure when they might next get that? Is there any like good video resources or other spaces that people could experience without having the experience of having someone on their team?
Right. I think some of the guidelines are good, like the best practices guidelines, the BC Center for Substance Use, the BCCDC, a number of different organizations like that do have different resource pages and stuff on peer support. I think Vicki Reynolds' work kind of stood out to me just because it's more about challenging our own biases and values as well, which I think is really important for peer integration into teams. We all have biases, and some of them we're more aware of than others. And I think, you know, taking a look at some of the work that Vicki Reynolds has out there right now around justice doing and taking lived experience into consideration is really important. I found that a lot of the health authorities do have resources being developed. I know Interior Health has some really good resources that are being developed now for developing peer programs and peer support. A lot of it's evolving as peer programs are growing. So I find that it's still sort of up and coming, but yeah, those are a few of the things off the top of my mind. There's some good research articles out there too now, increasingly.
Erica's also shared that there's a webinar called The Role of the Peer Within a Clinical Team is a great resource around peer skill set and role clarity. And Tamara just sharing the resources around trauma-informed practice, stigma, and trans care in BC are also helpful resources. Folks who signed up for, go ahead.
I was just gonna say, I'm happy to share my email as well too. And if people are interested too, if people want to shoot me an email, I'm happy to share some of the different resources that I came across in my research too.
That would be great. We can pop that in the chat. And also for folks who attended today or signed up for this, the recording will be shared. And so you can feel free to share that more broadly in your teams as well. And you can always reach back to our fellowship team as well for any questions or any suggestions too that we can share out. And shared amazing work, Deb. I'm so grateful to be part of the many teams here in the South Okanagan. From being an honorary and paid peer to an employed paid peer, I can truly say that peer work has played a huge part in my recovery and journey. These conversations and researches are needed for the continued growth of peer work. So thank you for helping to share and provide the needed insight into how peer work is needed in our services.
Thanks, Dion. And Dion's a good example of someone I've learned so much from. So
there aren't any more questions. I think that's a pretty wonderful way to wrap it up. Thank you so much, Dion, and others who shared comments in the chat. Deb, do you have any final words?
no, just really appreciate everyone coming out today. Because I have a lot of gratitude for being able to present on this topic, but just working alongside the peers has really, truly been transformative for me. And I've just learned so much, and I hope to see this work really grow, because I think we're well poised right now to really start to shake things up in the substance use world. So
thank you so much, Deb. A reminder to folks, if you can fill out our evaluation survey, it's in the chat. And yeah, thank you, Deb, so much for all the work you put into this really amazing presentation. That's a really wonderful resource now going forward. So thank you. And thanks everyone for joining, and have a great rest of your day.